goggles in one of these drawers. The drawers have a bunch of goggles in it. Not only that, but you guys all need to revisit how to hook the suction up. Okay? So if you come into your checkoff and the suction's all here and everything's all nicely, tightly wrapped up, and you have to actually, hook it all up, make sure that you remember where things go, how you're supposed to hook them up, and where you're supposed to turn this on, whether it be regular or intermittent. Now, why would you use intermittent to suction a patient, or why wouldn't you?
Oxygen. No, suction for less than suction.
Okay, so if so if you're suctioning the patient, you want to have continuous suction, because you want to be the one that's controlling the volume of suction, or the rate at which you're suctioning. So make sure you turn it on and regular. The intermittent is for NG tube suctioning, gastric suctioning, things of that nature. If you try to suction a patient on intermittent, and you're trying to get something out of their either tracheostomy or out of their mouth, and you have it set to 120, whenever it turns on, you're going to be waiting. Patient's choking. They're choking. And when it finally turns on, after who knows 30 seconds, you're barely getting anything. And then it slowly builds up to that 120, then it stops. So that's why you don't use the intermittent when you're doing oral suctioning or tracheal suctioning. You're the one that's controlling the pressure of the suctioning. You're going to do it in a rhythmic fashion to where you always want to make sure it works. To where whenever you're actually suctioning the patient, you do it several times. Like that. While you're withdrawing the catheter, whether it be tracheostomy or through just the oral suctioning, it doesn't matter. You're the one that's controlling the suction. Everybody understand that? Mm-hmm. This is a Youngcower. Youngcowers come in many different colors, so don't be surprised if you see clear ones. A clear one's not something else. It's a Youngcower still. So for the actual suctioning of the patient, you might have an inline catheter, which I'll find one of those that if they're hooked up to a ventilator, they'll have that. It's like an accordion style connection piece, and it comes with a ballard. And that portion is hooked up to the suction device, and the oxygenation is coming through the side. Whether it be a blow-by or a ventilator, that's how the patient is getting oxygenated. So with the inline suctioning, all you would do is just advance the catheter with clean gloves. Okay. Some of these catheters, like this one, you don't have to use sterile gloves, but we're going to use sterile gloves for all of them, for the sake of you guys trying to remember which is which and what is what. And my left shoe goes on the left foot, my right shoe goes on the right foot. Don't make it more complicated. So you're always going to use sterile gloves when you're dealing with any of this stuff. You have your cup here, and this particular one that you can use to pour your sterile water in. So if you happen to choose this one, the order of operations, just like any other math problem that you do, you have to work with this stuff first so that you know what you can touch, what you can't touch. So with your sterile gloves on, obviously you can't touch all this stuff and put your hands in it, because once you do that, you can't touch this again. Okay? So you want to, if you're going to use this one, you're going to take it out with some clean gloves, like it was, just like this, and it was collapsed. Put it on the side, open it up, take your other clean gloves, fill it up with water. Once you do that, that should be plenty of water. If you need more water, you can ask the instructor for more water. Once you touch the catheter, this is when your sterile gloves come into play. This is a sterile coating though. So the catheter is on the inside, so you're not harming the patient. This is just another one of the ways that they've designed this to make it nursing care easier, so that you don't end up, putting anything infectious into the patients. And the way that this works is it just slides out around the wrapping and it closes. Okay, about 12 centimeters, 5 to 6 inches. If you want to look on there, you can count all the way up to 12. This mannequins, I don't even know if you can get it in there that deep, because there's a little portion that stops you from doing that. So if you go all the way in, you're going to go down to the base of their lung, which is not the purpose of suctioning the patient. That's for a bronchoscopy. You're not doing that. just so that you remember, as soon as you pick up the catheter, whether it be this one, or the one in here, because these don't have a sleeve, whenever you've touched this, everything is now, this is going to have to be your clean hand, whichever hand is your dominant hand. So before you even grab the catheter, you're going to, also you have clean gloves on still. You're going to take this off, make sure all this stuff is on, make sure it's on, everything's on. Sterile glove, you can now put that down, take off your clean gloves, put on a pair of sterile gloves, grab this with your sterile glove, grab this with your other sterile glove. These are clean now. Nothing, it doesn't leave here. It just stays here the whole time. If you need to adjust anything else, touch this, touch that, and knock that over, or if it comes undone, you have a clean hand to help with the patient. So I'm saying use your dominant hand. And then whenever you need to actually do anything, when you're going to do the suctioning, just pull it down. All the way to about 12 to 15 centimeters on there. And then whenever you stick it inside the patient's tracheostomy, if you want to lubricate it first, that's fine. You can stick it in the sterile water, lubricate it first. That's also used so that you can get all the mucus that you're going to probably trap and get out of their tracheostomy. Get it all out of there. Don't tend to try not to use this for their nose, their mouth, in and around. Go inside the tracheostomy, come out. And if you happen to actually make them vomit or something like that, or if there's other secretions, you put the young power on and do that. This is meant to be for one use only. It's not something like you use it once and save it in the room, use it again, you use it again, use it again. So it's meant for you to use it just for this one time. So if you're suctioning a patient every 1 hour, every 2 hours, or whatever the case may be, you should get a new one every time you do it, every additional time. So one of the first things you want to do, as soon as you get all your stuff hooked up, you have the patient hooked up to their vitals. And if you don't have a portable machine in the room, you need to get one in the room. You need to watch their oxygenation primarily. You need to watch their heart rate, their breathing, their level of anxiety. Patients get extremely nervous when you start coming at them with anything that's going to suck the oxygen out of them. They're already having a hard time breathing, and you're going to make it even more difficult. So you need to hyperoxygenate the patient first. If they're on a ventilator, you hit it 100%, it's going to go for 2 minutes. If they're on blow-by or a T-piece, which is a different type of ventilation where the patient's actually breathing a higher percentage oxygenation and they're breathing on their own, increase it to 50% if they're on 30%. If they're on 40%, increase it just a little bit extra just for the time while you're doing the procedure. So they have increased oxygenation. And you can see that they're getting an increase in oxygenation by hopefully you see a rise in their SpO2 if that's appropriate. If the patient has COPD, you're not going to increase it greatly, and please don't leave it that way for long periods of time. If you need help doing this, please always, always, always get another nurse or the respiratory therapist to aid you in doing this with a patient, especially if the patient's extremely anxious or anxietal about anything that has to do with probably their tracheostomy, okay, or breathing in general. You guys had a question on your study guide talking about sterile water or saline installation to loosen up mucosal secretions. What do you guys think about that? What did the research tell you? Anybody?
Not effective.
It's not effective. Don't do that. Sometimes you will see respiratory therapists that are doing that, and I've tried to talk to some of them. Some of them are quite educated, and they do it because that's the way it's always been done. That's what they've always done, and it works for them. Don't do that. Okay, don't instill saline down someone's airway, because once it goes down their airway, you really think you're going to be able to get every drop of that out of their airway. You're going to have them coughing, 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 and if they cough so hard, maybe their stitches aren't in there, and they'll cough their tracheostomy out. Sometimes they can cough so hard, or they cough so hard and they end up, causing vomit reflex and they start throwing up. Things can happen where patients don't like it. Don't stick excessive amounts of saline down there. Encourage the patient to cough and deep breathe, cough and deep breathe. Get them chest percussion therapy if you need to. Get them other types of nebulizer treatments to help, dilute the mucosal secretions, and they have really good ones that work very well. So there's no need for us to instill saline down the tracheostomy, down the endotracheal tube or anything to try to technically loosen up those secretions. All you're doing is drowning the patient. Okay, that's all you're going to do. So, patients hooked up to their vital signs, saturations are 93, 94%. You increase the amount of oxygen over the time while you're actually doing the suctioning. Patient's oxygenation comes up to 98, 99%. That's when you go ahead and proceed with the actual suctioning. So whenever you're actually doing the suctioning, you always want to educate the patient, talk to the patient, talk them off the ledge for the most time, because a lot of patients don't want you to suction them. They hate it. It makes them cough aggressively. It makes them feel like they're drowning. You're taking all the oxygen away from them, so you have to try to, educate them, talk them into it, calmly get them through the whole procedure. And whenever you're suctioning them, you don't want to stick it down in there. You're not pumping gas, okay? You don't stick it in there and just hold on, it's suctioning. Yeah, you're getting all this good mucus out of there. They're not getting any oxygen this whole time. So whenever you're suctioning them, it's, you can do like every 2 to 3 seconds, suction, suction, let go. Suction, suction, let go. Suction, suction, let go. Suction, suction, let go. About 15 seconds or less. And as you stick it all the way down, and I'm going to show you, it's very quick. Stick it all the way down. And you want to take those little pieces as to mine. And if you guys look at this enough and you practice it enough, I mean, I don't know how else to give you guys a good parameter to know how to use these type, the external ones. You never want to do it to where you've got it going like a snake and you're trying to get it in there like this. That's too long. Okay, so 5 to 6 inches is more than enough, and that's roughly about 12 centimeters. You can take out a ruler too if you want to and measure it, and you'll have an exact amount. But have an eyeball amount, maybe from their chin to the top of their forehead. That's all you need. Okay, everybody's different though. So, but if you stick it in there and it bounces, you've hit something. So don't try to jam it in there further. Okay, the patient has to cough, get the mucus up to the point where the tracheostomy inserts into the trachea so that you can get that excessive secretions out of there, help them breathe more effectively. Because like you guys saw in the video, there's that little balloon that's sitting in there, and it could be just, collecting all around the bottom of that balloon. And you're just trying to get down in there just a little bit to where you could suction all that stuff that's collecting in that area. Because they can't cough it up and get it out. Not yet. Okay, so a little bit of lubrication. You've already encouraged the patient and talked to them. You told them it's only going to take a couple of seconds. You might have to do it once or twice. Just bear with me. If you have to, hold down. Here's a towel. Squeeze onto that. You can have another nurse in there, hold their hand, a family member, or whatever, because a lot of people do not like it. You're going to slowly insert the catheter inside the tracheostomy. You don't suction on the way down. Okay? You get all the way down to that 12 centimeter mark, and if you push it further, you'll find out that these dummies, or these mannequins, it stops at 14. Okay? So you get all the way to 12, and you start suctioning. And as you're suctioning, you're kind of moving it around like a little toilet bowl, you know what I'm saying? You kind of suction it all out of there because it's hanging around all on the inside of there. So you do it once, and you hear that there's a lot of secretions in there. You see that there's a lot of secretions in there, whether they're thick, they're thin, they're bloody, they're yellow, they're green, copious amounts, pink, frothy. There's all these different terminologies for describing the way that sputum looks. If you see that there's a lot, you're going to have to go down again, Mr. Jones, Mr. whatever, Mrs. whoever. We're going to have to do this, 1 or 2 more times. You don't just immediately go right back in there. You got to give them a time to recover. Give them a time to see if their pulse ox actually drops, because sometimes there's a lag depending on the equipment that you're using. You don't want to suction, everything's 98%, and you go, oh, it's 98%, go down in there, and all of a sudden it dropped to 60, 70. It starts dropping really quickly. You don't want that to happen. So give the patient a chance to recover. They've recovered, sometimes it takes a minute or two. They calm down with their coughing, they catch their breath somewhat, and then you go down again. You try not to go down any more than 3 times. If you have to go down more than that and there's lots of secretions, you're getting getting like 10, 15, 20 milliliters, talk to the doctor and get an order for a bronchoscopy. Have the pulmonologist check them out, because they have more in there than you can actually get out of there effectively and safely. And that's what we're trying to do, safely remove the mucosal secretions so that the patient doesn't choke on them and their airway is patent and their respiratory status doesn't come further compromised. They already have it compromised somehow, so we don't want to further harm them. So that's how you use this one. And this stays like pretty much at the tip the whole time. You can move the catheter, and I'm never, compromising my sterile hand. Okay? And you guys have to work through all these different kits with your own mind. So This one right